Dear doctors, on behalf of GE Healthcare, it gives me immense pleasure to introduce Dr. B.S.Rama to today's webinar on fetal echocardiography practical guidelines. Dr. Ramurthy is a very senior radiologist and has a very strong inclination towards fetal medicine. Dr. Ramurthy enjoys teaching, and one of his recent book on fetal neurosonogram has received great reviews. I once again welcome sir for today's webinar.
A very good evening, friends. Thanks, Mr. Madan, for that introduction. In the next 1 hour or so, we'll try to look at the fetal heart, what is expected of us to assess the fetal heart when we do a mid-trimester anomaly scan. Right? Now, we need to understand that CHD, or congenital heart disease, is a common disorder in the fetus. It's the commonest congenital anomaly that can occur in a fetus. So much so that 8 per 1,000 live births are affected, 8 neonates per 1,000 live births are affected by congenital heart disease. And half of them need postnatal surgery or catheter procedures. Therefore, half of them are complex diseases. So 4 per 1,000 or 0.4% is the incidence, which is a huge incidence, right? Now, that means we need to screen the fetus for congenital heart disease. Now, when we talk of screening, we need to understand that screening is the strategy, because if you look at obstetric practice, about 80% of congenital heart disease that we pick up come from the low-risk group, whereas only 20% yield of picking up a fetal heart disease comes from the classical high-risk group. Now, what is this high-risk group? High-risk group could be historic, maybe do a maternal or paternal or sibling history of congenital heart disease. Now we have many ladies who have been operated for tetralogy of Fallot, who have been operated for other congenital heart disease, who themselves have become adults, who are now conceiving. So those ladies are belonging to the high risk. Also maternal history in terms of diabetes mellitus, infection, antibodies like anti-Rho, anti-LA, drugs, and assisted reproductive techniques, again, contribute to the high-risk group. And lastly, the fetal, a very important contributor. You've done a first trimester scan and you find a thick NT, a tricuspid regurgitation, ductus venosus, A-wave reversals, or a combination of that. You find extra cardiac anomalies, abnormal findings on a first trimester cardiac study. Now, we all do our inflow tracts, which are parallel, using color in the 11 to 14 week scan. We also do look for the outflow tracts which are crossing over in the first trimester scan itself. So in the process of looking at the first trimester heart, you might have findings which will tell you that this is a case which you have to follow up in the near future, maybe 15 weeks, 16 weeks, 17 weeks, or even the mid-trimester, to see if there's congenital heart disease. A hydropic fetus is also a fetus which can potentially have a cardiac anomaly. Aneuploid fetuses, you've done an aneuploidy screen, you've got a screen positive case, you've done a karyotype and karyotype reveals an abnormal, you've done a invasive testing and karyotype reveals abnormal karyotype, and that fetus should receive a good fetal cardiac study, because aneuploid fetuses do have a high incidence of CHD. Monochorionic twinning, extremely important, because the heart gets involved because of the volume exchanges that occur, and therefore we must put a monochorionic twinning into the high-risk group. So all the others, without any of these factors, the regular run-of-the-mill case belongs to the low-risk group. Now you would ask me, why does the high-risk group contribute only 20%, whereas the low-risk group, where you expect not much of congenital heart disease, giving you 80%. The reason is that the low-risk group is a huge proportion of the population, and that is why you get the greatest contribution, the bulk of the cardiac disease, CHD, from the low-risk group. And therefore, we cannot say, I will look at the heart only in high-risk cases. Wrong. You will look at the heart in every case, every fetus that comes under your care, which means that it's universal screening. When you say universal screening, you open it up to all the fetuses that come up under your care. Now, you can do this in the first trimester. You can do this in the second trimester, and this presentation will take you through what happens in the second trimester or the classical mid-trimester anomaly scan. Now, the term that we use to represent the cardiac examination in the mid-trimester is called extended basic examination. Extended basic because the basic alone gave us only the 4-chamber view as a guideline, but we know that the pickup with 4-chamber view alone is very, very low, and therefore you've got to extend it. Now, how do you extend it? It is by looking at the upper abdomen, 4-chamber view, LVOT, RVOT, and the 3-vessel view. I've put all these in white. You also have the 5-chamber view, which you get when you go from 4-chamber view to 3-vessel trachea view. You get your 5-chamber view and the 3-vessel view en route from 4-chamber to the 3-vessel trachea view. So therefore, you can, if you regard these also as views, you will have 2 more, but if you don't take these into consideration, you have 2 less. So upper abdomen, 4-chamber, LVOT, RVOT, 3VT. Remember, echocardiography does not start in the fetal thorax, it starts in the fetal abdomen, and therefore the first plane that we have to look for and make it a protocol driven is that we start with the upper abdomen, right? So this is the minimum basic protocol that we follow in every mid-trimester anomaly scan. This is not a high-end fetal echocardiography that we are talking about. It's just the entry level. It's just what bare minimum that we need to do to this particular fetus when you see the fetus in the mid-trimester anomaly scan window. Now, what do we employ? We use grayscale, or also known as B mode. You use M mode, you use color Doppler. Color Doppler, in fact, is a necessity. It is not that you turn the color Doppler on when there's an abnormality. You turn the color Doppler on default in every case, and I'll show you some cases where this has actually helped. Whereas spectral Doppler, tissue Doppler, 4D, and things like spectral tracking, so on and so forth, are a part of the traditional fetal, specialized fetal echocardiography or advanced fetal echocardiography. So what we will do really in this presentation is to look at the extended basic examination. And the first plane, as I said, starts from the upper abdomen. So in the upper abdomen, you need to have a transverse section. This is an axial section, and that's how the section runs through the upper abdomen. We need to first look at the fetus in terms of its orientation in space. Because once you know that a fetus is oriented in such a position, in a particular position, you will call off your own. If you imagine yourself in the fetal position, you will call your right as the fetal right. You will call your left as the fetal left. And that's extremely, extremely important to mark the sides of the fetus, And having marked the sides of the fetus, I know that this is left and this is right, because the spine is here and I have done the scan. This is a cephalic presentation. The head is in the lower pole of the uterus and the breech is in the fundus. So in this orientation, I know my left is this, my right is this, if I put myself in the fetal position, and therefore the fetal left and fetal right. After having allotted the sides to the fetus, I'm going to look at the transverse section of the abdomen and simply allot the sides which are being taken by certain key structures. The first key structure I'm going to look for is the stomach, and the stomach is clearly left-sided. Left-sided, left of the line which you can imagine through the median there. So left-sided stomach. The bulk of the liver is right-sided. You can see that there. You can see a bit of the spleen over here behind the stomach, which is also left-sided. The aorta is in the center, but not bang center. It's to the left of the center. It's center left, and the IVC over here is actually a little bit to the right of the IVC, and IVC is to the right of the aorta and anterior to the aorta. Now all this takes is actually 2 seconds to say that this is left, this is right, stomach on the left, liver over here, aorta on the left, and the IVC anterior to the aorta and to the right of the aorta. So once this is done, you know that the organs in the stomach are organized in the proper fashion and there is no abnormality as far as location, as far as situs goes in the abdomen. So abdominal situs is normal. Now we have to move on to the next, and the next is the all-important 4-chamber view. And remember, the transducer which was cutting axially in the upper abdomen now is moved translatory shift. You do no angulation, nothing, no angulation, no rotation of the transducer, nothing whatsoever. You move from one level into the next level. So from the 4-chamber, from the upper abdomen, you go into the thorax. And when you go into the thorax, you find that the 4-chamber view comes into your the view, and you need to look at the 4-chamber view in a certain way, and that certain way is extremely important. We'll do that. So if there is a message in this presentation, what I'm doing, it is the checklist that one has to run when one obtains a view. You know how to obtain a view now. That's the grayscale. You know how to put in color, and you know the settings. You have done your equipment settings very well, and you know that you've got to turn the color on. So you've got these 2 clips with you, but what are you going to do with these clips will come a little later. So first we'll run through the transducer shifts, getting what we want, and then the all-important checklists we'll go through into each of these views. Now, to get the LVOT, my starting point was a 4-chamber view, which was an axial view, and now I have clockwise rotated the transducer by 45 degrees. When I do that, I get the classical LVOT that you see here, LVOT, and that's the color LVOT. You can see the aorta taking the blood away from the transducer in blue, and that's the aorta in grayscale imaging, right? Now, from 45 degrees, when I go bang mid-sagittal, another 45 degrees, so which totals up to 90 degrees from your axial, you get your RVOT. And RVOT is a mid-sagittal view almost. So you see the sternum there, anterior chest wall, you see the posterior chest wall, you see the spine happening there, and then you have the right ventricle and the pulmonary artery. You have the right ventricle there and the pulmonary artery. So it's almost a mid-sagittal section. So axial view of the 4-chamber, then you move 45 degrees, LVOT, another 45 degrees is your RVOT. Now you come back. Once you have finished your RVOT and LVOT, you get back to your 3-vessel view. You get back to your 4-chamber view. You know how to do it. You derotate. You had gone clockwise, you go anti-clockwise, get your axial view, recover your 4-chamber view, and then from this level, you do another translatory shift upwards. Just like you moved from the upper abdomen, you moved into the thorax by a translatory shift, another translatory shift above, you get through your superior mediastinum, and in the superior mediastinum, you have your what are the vessels that you see here? From the right to the left, you have the SVC happening, then the aorta, then the pulmonary artery. That's the right, that's the left. So you'll have to look at the 3-vessel view. 3-vessel view in color, you will realize that it's the same color happening in both, because both are taking blood towards the descending aorta. Now we'll come to the checklist later on, and that's how you get your 3-vessel trachea view. When you move from the 4-chamber view towards the 3-vessel view, you actually go through 2 more views. One is the 5-chamber view, and the other is the 3-vessel view, which we really don't document. You can see it, but you don't document it. Your documentation is mainly of the 3-vessel trachea view and the 4-chamber view. So indeed, you're left with 3 axial planes and 2 non-axial planes. right? So those are the 5 planes which will help you to do your sequential analysis, to do your looking at the heart as a whole organ, right? So let's look at this concept of cephalic sweep. Now, when you do a cephalic sweep, you will have to start from the upper abdomen and move towards the 4-chamber view, 5-chamber view, and then, of course, you can come into the 3-vessel trachea view. When you do a cephalic sweep, you're actually trying to trap all the axial views into your clip. What I showed you before was individual clips of 4-chamber, individual LVOT, 3-vessel, so on and so forth. Here is a sweep which gets everything into your one clip, and that helps you to study relationships. So therefore, now this is a cephalad sweep. What I'm going to do is to just recover all the views that we spoke of. See, the first bookmark I've done gives you the abdomen. The second bookmark I've done gives you the 4-chamber view. The third bookmark I've done gives you the 5-chamber view. That's the aorta. You still have the 4 chambers, so you call it the 5-chamber view. Then you have the 3-vessel view. 3-vessel view. What you have is the pulmonary artery, left, aorta, and the IVC. You don't have the aortic arch here. You only have the pulmonary artery and the ductus arch. You have in long section, you have the short section of the aorta, and you have the SVC here. That's the trachea, which is actually dividing into the carina over here. It's actually bifurcating into the 2 bronchi there. So this is a 3-vessel view. And also remember the fact that in one plane, if you're cutting the long axis of one great artery, and in the same plane, if you see the short axis of the other artery, these 2 arteries must be perpendicular to each other, which tells us that this is an excellent way to show that yes, you have recognized that the 2 great arteries are perpendicular to each other at their origins. Now, after having done the 3-vessel view, you go on there, you get the 3-vessel trachea view. Now, in the 3-vessel trachea view, you already have the ductus arch. The aortic arch comes in over here, and you have this V happening. That's the SVC. This is the trachea, and we'll see a bit more of this when we go to that particular plane for discussion. So when I play the clip, you will realize that all these unfold in front of you, and as you see, you find the aorta going this way, the pulmonary artery going this way, again telling you that there's a crossover. So store a clip, just like you store all those individual planes. I think you should store a clip as well, which will give you the perspective of the crossover very, very well. Now we'll come on to the 4-chamber view. Now, before we jump into the 4-chamber view and try and identify the vessels, the connections, the chambers, so on and so forth, we need to look at the heart as a whole. When you look at the heart as a whole, you need to look for the cardiac situs, the size, the squeeze, the axis, and the position. Okay, this is the SSAP, or in the reverse it is PASSS, right? So we need to look for all this, and when we look for all this, you look at the heart as a whole organ. You've not yet split it up into its constituent chambers and vessels. You're looking at it as one whole organ, and this is where we again slip up. As soon as we get the 4-chamber view, we are too excited. We say, okay, this is LARA, this is, and these are the connections, so on and so forth. We should refrain. We should look at the heart as a whole and then move on to the sequential segmental analysis. Now, how do we see the heart as a whole? So the first thing is cardiac situs. This is from the ISWAC guidelines. I've just made a cut and paste, but I won't read through this. I'll take you through this, which in effect is going through all these points per se, right? So therefore, situs is important. We realize that the upper abdomen, we know how to do the situs. Similarly, in the 4-chamber view, we need to look at the cardiac situs. And in doing the cardiac situs, we realize that this is the left side, the stomach is on the left side, and you also realize that the apex of the heart is to the left side as well. The descending aorta is also a little to the left side of the spine. So therefore, the thoracic arrangement of the viscera and the abdominal arrangement of the viscera are normal. Now let's look at this particular case. Here is the sides of the fetus marked for you. That's the left, right and right. You start with the abdomen and you get a headway clue. Even before you come to the four-chamber view, the heart, the stomach is on the right side. The liver looks a little largish, extending from side to side, and already you have a warning system in place. You're being warned that, look, there's a situs abnormality, look at the thorax carefully. You might find a thoracic abnormality, you might find a cardiac abnormality, and true enough, when you get into the four-chamber view, the apex of the heart is now to the left side. So the apex is left, the stomach to the right, and therefore this is classical situs ambiguous. It's neither situs solatus, it's neither situs inversus totalis, which leaves you in the situs ambiguous category. And even without me telling you, you know that this is an abnormal four-chamber view showing you a complete balanced AVSD. There's a single AV orifice over here. That is a complete balanced AVSD. And of course, you see the area behind the heart is so huge. There's an anomalous pulmonary vein which is going across. And all this, you had already your clue in the abdomen before you came into the thorax. So that is why please start with the abdomen. Please start with situs. Extremely, extremely important. The size is important. The size, the heart, the normal heart occupies about 1/3 the area of the thorax. So 1/3 right lung, 1/3 left lung, 1/3 is the heart. Now, you can do this subjectively, and that is what we do in our daily practices. We don't go around measuring these area cardiothoracic ratio or circumference cardiothoracic ratio in every case that we see. You eyeball, and if your eyeballing tells you that the cardiac size is normal, you don't go around measuring. But if you have to measure, you can measure in terms of area CTR or circumference CTR. You need to draw perimeters around the thorax, perimeter around the heart, and if you're using area, 33%. Any area cardiothoracic ratio more than 33% is cardiomegaly. Anything on the circumference CTR more than 50% is cardiomegaly. Now let's look at this clip. Here is a heart which is definitely large. I'm not going to go and measure the CT ratio. It's heart, it's large, it's globular. Normal heart is more longer, then wider, then a globular heart, where the globular heart is also wider in comparison with the length. So it's a globular heart, it's an enlarged heart, and of course you also realize that the contractility of the ventricular myocardium is poor. You see that the cardiac ventricle is not really contracting very well. Compare this to this. Look at the myocardium here, brilliantly contracting. This is poor contractility, dyskinesia, and because the contractility is no good, the passage of blood from the atria to the ventricle is also no good. The atria are also not contracting well. When the blood flow is no good, passing from atria to ventricle, the valves don't open and shut like this. You can see the valves which are opening brilliantly, very, very exuberantly opening here. Here they are not opening at all. And you see this is called the clapping hand sign. You see that the valves don't fully open, they just go a little bit and then they come back. So that's an example of dyskinesia. So squeeze is not there, cardiomegaly, yes. Right, and now we go on to another important point, and that is cardiac axis. We all know that the axis of the heart is done by two straight lines. You draw a straight line through the, across the spine and the sternum, and one across the interventricular septum, interradial septum, and this should be between 25 and 65 degrees, right? Whereas, look at this. Here is a heart which shows you that this angle is much, much more than 65 degrees. It's almost close to 90 degrees. So you call this axis rotation of the heart, and it's towards the left side, so it's a left axis rotation. Some people use the term left axis deviation. And why are we looking at this? This is again a very strong marker of conotruncal abnormalities, of outflow tract abnormalities. Now, in the same case, when I show you the LVOT, you will realize that there is a malalignment. VSD over here, overriding of the aorta, and the pulmonary artery in this particular case was narrow, and that's a tetralogy of fellow that you're dealing with. So the axis rotation was actually telling you that there could be a lurking conotruncal anomaly or an outflow tract anomaly, and true enough, you picked it up. So just like the situs, you have the axis, which also is a potential warning system which is inbuilt into your protocol. From there, we move on to the shift. So remember, axis is the heart turning on its own vertical axis, whereas shift is the heart moving one side or the other side. That was a turning or rotation on the central axis of the heart. That's axis rotation, whereas this is a translatory shift across. So this is easier to understand, and if there is a space occupying lesion on one side of the heart, you get the heart displaced to the other side. So here is a left microcystic congenital pulmonary airway malformation. The heart is shifted to the right. Here is a pleural effusion there under tension, and the heart is shifted to the right. Here is a right lung aplasia. This is a pull phenomenon, not a push phenomenon. The left lung is normal, the right lung is missing, and the heart has simply moved to the right side. So it's a pull phenomenon which has occurred. This is a bronchogenic cyst, right lung. The heart is moved to the left side, and these are all very, very evident cases. Let's stop these clips. These are all very evident, but in less evident cases, you need to be very, very critical in your observation. Critical in the sense that if you draw a midline median from the spine to the sternum, in the normal situation, that's the line I'm talking about. This is the line. Sorry, this is the sternum. This is the if you look at the heart in relation to this line, you'll find 2/3 of the heart to the left and only 1/3 of the heart to the right of the line. And that is one thing we should bear in mind. Now, if you have that concept and if you have that in your checklist, when you do your heart as a whole, in that light, I want you to see this. Now, imagine a straight line here. What's happened? This is left. This is right. You had to see only 1/3 of the heart to the right of the line. And what's happening here? You have almost the whole heart. Almost the whole heart is to the right side, right? If you're tired, you might, towards the end of the day especially, you might miss this happening. You might say, oh, it's normal, the four-chamber view, but actually there's a mediastinal shift. And the mediastinal shift to the right is due to something happening in the thorax there. Now, I want you to see the echo pattern here. That's the lung echo pattern. The echo pattern here is definitely not that of the lung. You will see that it's intestine. This is only intestine herniating into the thorax. The stomach is intra-abdominal, and this is the MRI of the same fetus showing you the normal right lung there, but this is the bowel that you see on MRI. And again, if you draw a line here, you will realize that more than 2/3 of the heart is moved to the right, very little left on to the left, and that is due to this only intestine congenital diaphragmatic hernia. So oftentimes especially when there's a right-sided cardiac, when there's a right-sided diaphragmatic hernia, or when there's only bowel left-sided hernia, the mediastinal shift is the one which gives you the headway clue, and building on this clue, you can reach your final diagnosis, right? So from there, we move on to the issue of pericardial fluid. Now here is an image that you see here. That's the four-chamber view of the heart, and you have some fluid happening there. Some fluid happening outside the heart over here. This is normal. This is normal pericardial fluid. That's normal pericardial fluid that you have here. You can see that sliver of fluid is normal. Not to call it pericardial effusion, the cutoff is 2 millimeters. If you measure the thickness of the fluid, an inner to inner measurement, and it's less than 2 millimeters, that is not pericardial effusion. Whereas here, in this particular case, you have some floating echoes in the fluid out there, and also the pericardial effusion definitely is more than 2 millimeters. I would definitely use the word pericardial effusion here, there's no doubt about it. The heart also is enlarged. If you carefully look, the heart is definitely enlarged, the cardiomegaly which has happened there. And in this case, of course, it's a huge pericardial effusion. Those are the lungs which are pushed behind. This is not a pleural effusion because the lungs are pushed backwards posteriorly, and this is the heart, which is a classical rocking kind of a movement that you see, a floating heart in a pericardial effusion, right? Now the rate is extremely important. The rate is the cardiac rate, and one look at this clip tells you that the ventricles are very slow. They are, they are not beating, they are not as busy as they should look. Whereas the atria look busy. You have almost 3 beats of the atrium to 1 beat of the ventricle. The ventricular myocardium is thick. It's faintly hyperechoic. It looks rather spongy. And most importantly, the crux of the heart is absent. You have an AVSD which is happening, and there's an AV regurgitation also that you can see in blue over here. So the first abnormal finding that you can get in a four-chamber view of the heart indeed can be the rate. So when you look at the heart, and because you've seen so many hearts with normal heart rate, once you have a tachycardia or a bradycardia, you will know that this is a problem by just eyeballing. And once you have eyeballed, you will use your M mode, and you will find out that the atrial heart rate is 124, 142. The ventricular heart rate is 56, which translates roughly into a 3:1 heart block, a second degree heart block that you have. So much for looking at the heart as a whole organ. Now we move on to sequential segmental analysis. And what is this segmental analysis all about? We need to understand that the heart comprises of the venous level. The blood reaches the heart through the pulmonary veins on the left side, the SVC, IVC on the right side, reaches the atria connect up with the ventricles, and the ventricles pump blood into the great arteries, right? So there's a venous level, atrial level, ventricular level, arterial level. So the 4 levels connected by 3 junctions, the veno-atrial, the atrioventricular, and the ventriculo-arterial junctions. And there are 2 sides to the heart, the right-sided heart structures, the left-sided heart structures, and therefore 2 sides, 3 junctions, a total of 6 connections. So if you, by using your skill and using all the views that we've already seen now, and which we will take the checklist up now, if you, by your skill, are able to say that these 6 connections are normal, you would have said that this is a normally connected heart. And that is what sequential segmental analysis is all about, right? Now, okay, so again, the ISWAG checklist over here. I'm not going to take you through these points. We will right away try and look for these points in the pictures that we're going to look at. One of the main things that we see when we look at the 4-chamber view is that there are 4 chambers, right? So the first and foremost, a 4-chamber view is called a 4-chamber view because you are able to very easily recognize 4 chambers in there. So if there are 2 chambers, if there are 3 chambers, your antenna go up, you know there's something wrong which is happening. So here are the 4 chambers that you can see, and not only 4 chambers, you also realize that the 2 atria are equal to each other, 2 ventricles are equal to each other. You also realize that the interventricular septum is intact. You have a crux of the heart which is happening. The crux of the heart has an offset, which means that the tricuspid is closer to the apex compared to the mitral, which is a little further away, right? So therefore, before we go further, we know how to identify our chambers. Always start with the fetal heart, with the spine. When you see a clip in a conference you're attending, or you're looking at this presentation going on now, how are you going to orient yourself? Look at the spine, and that's the descending aorta. Very close to the aorta is LA, and you have the pulmonary veins opening in over there. This is LA, and this is LV, so therefore this is mitral valve. This is left side, this is right side. You've already confirmed that in a preliminary step, which we've already gone through. Now, if this is LA and LV, this is RA and RV out there. So this is interventricular septum. This is the interatrial septum. This is called the septum primum, or that's the drumstick, which is very important to recognize. This is the foramen ovale over there. This is the tricuspid valve closer, mitral valve further. So you have the interventricular septum here. You have the interatrial septum here, and this small little bit over here, thanks to the offsetting of the tricuspid versus the mitral valve, you have a small segment of the septum which is separating the right atrium from the left ventricle. So this little septum is actually the AV septum. The AV septum, atrioventricular septum, interventricular septum, and interatrial septum. Very important to recognize all this, and of course the contractility of the heart we've already studied. So we said that these two chambers should equal each other. Those two chambers should equal each other. In the light of that, let's look at this clip. Here, you will definitely agree with me that the right atrium looks larger than the left atrium, and also the tricuspid valve looks a little abnormal compared to the mitral valve. Now, this valve shows a lot of offsetting. It should have been somewhere here, but it's moved closer to the apex, and when that happens, you know the diagnosis is Epstein's, and normally you immediately turn the color Doppler on, and when you turn the color Doppler on, you have tricuspid regurgitation, which starts way deep within the chamber of the right ventricle. Regurgitation should have started somewhere here, but because of the valvular displacement out there, the regurgitation starts from deeper within the chamber. So why is the right atrium dilated? It's dilated for two reasons. One is a part of the ventricle is now incorporated into the right atrium because of the valve shift over here, or the valve displacement, and you also have a tricuspid regurg. So that is an Epstein's anomaly, and the first thing which your eyes noticed was the disproportion between the left atrium and the right atrium. Now here is a grosser case that you can see. This is classically a left chamber which is very small. Not only small in the width, it is also small in the length. Normally the apex of the heart, if you look at the normal four-chamber view of the heart, the apex of the heart is always contributed to or made up by the left ventricle. Here, within a minute, you realize that the ventricle is very small, its walls are very echogenic. The left ventricle, of course, the walls are very echogenic. There is no squeeze. Look at the squeeze of the right ventricle. Here there's no squeeze. This is like a ball which is moving up and down. It's turgid. There's no contractility. And the apex of the heart is definitely taken over by the right ventricle. The mitral valve is not opening and closing at all over here. The tricuspid is doing its job. The foramen ovale flap, which should always normally open into which chamber? Into the left atrium. That is how you mark the left atrium. You mark the left atrium because the pulmonary veins going there, and also the flap of the foramen ovale is there. So therefore, that's the left atrium. That's the flap opening into the left atrium, and here you find the flap bulging into the right atrium, all features telling you that this is hypoplastic left heart syndrome. And when you look at the color, you find that there is no flow across the mitral valve at all. Flow across the tricuspid is good, normal, and you have a retro shift of blood from the LA into the RA. Normally it's from the RA to LA. Here you can see a red happening there. So it is retrograde shift that you can see which is happening there. And when you go on to the three-vessel trachea view, you'll find that the pulmonary artery is taking blood in the normal direction, but the aorta is small. It's taking blood in the reverse direction, telling you that this is a ductus-dependent systemic circulation, and the whole thing fits into a hyperplastic left heart syndrome. So extremely important to look critically at the contractility. Who's making the apex? Where is the flap opening and closing? And that will put your diagnosis on a firm footing. Now here is a four-chamber view of the heart again. Again, I don't see the chambers equal to each other. The left ventricle is small compared to the right ventricle. The length is okay. The width is the one which has taken a beating over here. And when I move into the three-vessel trachea view, because the left ventricular chamber is small, I expect that the aorta also is small. And true enough, you see an aorta. This is the pulmonary artery, this is the left side, this is the right side. You see the pulmonary artery, you see the aorta, that's the SVC, the right-sided SVC. You find that the aorta is much smaller than the pulmonary artery. It should be only slightly smaller. Here it is much smaller. It's almost the size of the SVC. It should be normally larger than the SVC. It's almost the size of the SVC. And there's also a fourth vessel over here, and that's the left SVC, the LSVC. So the aorta is small, the left-sided chambers, atrium and ventricle are small, all telling you that you might be dealing with a coarctation of aorta. And true enough, when you do the aortic arch view, you have an aortic arch which is very, very narrow. Those are the neck arteries which are starting there, and therefore you know that this is a coarctation of aorta with a left SVC at 32 weeks. At 20 weeks, this was a normal study, and I will not take you through the clips. It was, believe me, a normal study. So when you have a disproportion, you've got to actually objectify the disproportion. You fall back on Z scores, and this shows you the end diastolic diameters of the left and the right ventricle, the diameters of the pulmonary artery, the aorta, the isthmus of the aorta, so on and so forth. And with this, the cardiologist can really prognosticate and take this couple across with the appropriate counseling. So, okay, so just move out of this case. Like, let's look at this first trimester. This is a 12-week fetus that's in question, and you find that even in the first trimester, you have to recognize that the chambers should be equal to each other. Here, right away, you know that this is left, this is right. The right-sided chambers are large, the left-sided chambers are comparatively small, and when you turn the color Doppler on, you have a massive tricuspid regurg which is happening, not from the region of the AV ring, but it's starting deep from within the ventricle, almost from the apex, telling you again that this is an Epstein's anomaly, and you picked up an Epstein's anomaly at 12 weeks. Look at the nuchal translucency. Nuchal translucency definitely is thick, telling us that yes, a thick nuchal translucency is not only a marker of aneuploidy, it's also a marker for congenital heart disease. On the other hand, let's look at this particular case scenario, and here you have a four-chamber view. This is not working, doesn't matter really. I'll show you on the still itself. This is the spine, this is the LALV, this is the RARV. The RV is small, there's an interventricular septal defect, the tricuspid valve is thick and just like a diaphragm. The mitral valve is normal, and the left ventricular chamber is small. So when you go to the three-vessel view, you expect the pulmonary artery to be small, and true enough, the pulmonary artery is small compared to the aorta, and this is a classical tricuspid atresia with VSD, and your four-chamber view tells you very, very eloquently that the chamber asymmetry is eye-catching, and you know that the tricuspid valve is not moving. Normally, both the mitral and tricuspid should move well. Here, the tricuspid is not moving. The mitral alone is moving, a TAVSD. So, this clip works now. Yes, it's working. So you see the pulmonary veins over here. That's the crux of the heart. I'm going to take you through a few bookmarks here. That's the first bookmark showing you the crux, and that's the offset. Extremely important to recognize this. And here the AV valves are closed. That means you are looking at the heart in systole. In systole, the AV valves are closed, and you see a wonderful view of the crux. In diastole, what happens is that the valves open and your horizontal limbs disappear. So if you want to look at the crux of the heart, you will see it in systole in real time and not in diastole as you pan across your cine loop. Now let's look at this clip. That's a clip where for sure there is no offset. There is no crux at all. And why is there no crux? Because there is an inlet ventricular septal defect. There's an ostium primum defect over here, and the AV valve is one straight line across. There's no offset at all, and that's an AV, that's a atrioventricular septal defect. And also look at how anteriorly this heart has moved. Normally, the left atrium is extremely close to the descending aorta over here. You only have the esophagus here. Here it's moved a mile away, and there's an extra vessel there. That is the anomalous pulmonary vein, and when I trace it, the pulmonary vein goes in, the vertical vein goes infracardiac, penetrates the diaphragm, and you can see the vein joining the left portal vein, umbilical vein, ductus venosus complex over there. So that is a TAPVC infracardiac, and this is mainly to show you that yes, there is loss of offset that you can see there. Loss of offset, single orifice which is happening. Ostium primum which is floating. An ostium primum should never float. It should be attached, and that's why we call it a drumstick. That's floating out there, and all signs of a complete AVSD that's happening there. Okay, now here is a heterotaxy which is happening. That's the left-sided apex of the heart. Again, an AV septal defect. Look at the loss of offset there, and here you find that the stomach is left-sided, no doubt, but the heart, the liver is huge. It's going from side to side, and most importantly, in my checklist, when I look for the IVC is missing, and instead I see two vessels there. That's the descending abdominal aorta that you see here, and to the right of the abdominal aorta there's another tiny vessel. I hope you're able to recognize that, and that is the azygous vein. So absent IVC goes with an azygous vein which is large, and this azygous vein tells us that there is an interrupted IVC with an AVSD. I'm sure we are dealing with a right-sided atrial isomerism. The double vessel is also seen very, very well here. In fact, it's seen better over here. Look at the area behind the heart. You need to see only the descending aorta. That's the pulsatile descending aorta. Do you see a second vessel here which is not pulsatile? That is the azygous vein which has really become big, and this is not an abnormal vein. It's a normal vein. It becomes big, and you call it an azygous continuation, which is taking the abdominal venous return into the SVC. So you go down and look for the IVC in the long axis, long views. You don't find the IVC at all there, and you do your coronal views, you will find the aorta and the azygous are as parallel, as a double barrel sign that you see here, and this is right atrial isomerism. So a lot of clues happening over here. There is a crux which is abnormal, area behind the heart which is abnormal, and then you go on to unravel and finally say that this is a right atrial isomerism, heterotaxy. Okay, so now again, intrinsic ventricular features are important. As I said, this is normal. You see the tricuspid closer, that's the moderator band. Now watch this clip. This is left-sided, this is right-sided. The left-sided ventricle I'm used to seeing as an empty space here, whereas here the left-sided ventricle has got the moderator band. The left-sided mitral valve, the left ventricular valve, mitral valve, is far away from the apex. Here the so-called mitral valve is closer. So therefore this is not the mitral valve, this is the tricuspid valve, this is the moderator band. So the left-sided chamber is the right ventricle, the morphological right ventricle. This is the morphological left ventricle. This is the left atrium joining the left ventricle. This is the left atrium joining the morphological left ventricle, right atrium joining the morphological right ventricle, and that happens in CCTGA. So be very, very critical when you see your four-chamber view. Look for the intrinsic features. Once you begin to have this in your checklist, you will never miss a CCTGA. You will go on to the outflow tracts, and you will show that these outflow tracts are parallel to each other. That's the aorta, that's the pulmonary artery, and what is more, the aorta is left of the pulmonary artery, telling you that this is LTGA, the old terminology. The new terminology is CCTGA, or congenitally corrected transposition of great arteries. Now, the integrity of the interventricular septum is important. You need to know that you need to rule out gaps and bits of pieces of ventricular septum which are missing, and that's a muscular VSD which is seen on grayscale. Oftentimes you don't see it on grayscale. When you turn the color on, you have a marked biventricle bidirectional shunt which is happening across the interventricular septum. So turn the color Doppler on, you will see regurgitations which you may not expect. You might see flow across the ventricular septal defects which you may not see in the grayscale. Okay, so what are the number of connections that are assessed in four-chamber view? You have assessed both atrioventricular connections because you've seen both the mitral valve and the tricuspid valve. You've also assessed the left veno-atrial connections in the sense that you've seen the pulmonary arteries which are getting into the left atrium. So out of the 6 connections, you have actually wiped 3 of them neat, and that is why four-chamber view is extremely, extremely important. It gets you halfway across the sequential segmental analysis. And that's a recap of what we did, and that's the ISWOC guidelines. From there, we move on to the LVOT, and in LVOT, the first thing that we're going to do is to recognize the presence of a great artery. The great artery is there, yes or no? Yes, it is there. It starts from the left ventricle. Again, that's the spine to orient yourself. Spine, descending aorta, LA, LV, mitral valve. Can you see the mitral valve opening and closing there? Yes. So that is the great artery coming from the left ventricle, and the great artery is pointing to the right shoulder of this particular fetus, right shoulder. That's the classical direction which we must acknowledge. We also should realize that the aorta has an anterior wall and a posterior wall. When I trace the anterior wall, it goes into the interventricular septum, and this continuity is extremely important. Membranous VSDs come out over here, and this is important to document. The posterior wall actually continues into the anterior leaflet of the mitral valve. So aortoseptal, aortomitral continuity. The cusps of the aortic valve are thin, they are not thick. And if you see the cusps, they only come together in diastole. In systole, they open, they disappear. In diastole, they come back. So its blinking aortic valve is extremely important to say that this aortic valve is normal. Now, here is the first clip that I'm going to show you. That is a LVOT, and from a mile away you know that the anterior wall of the aorta is discontinuous with the rest, and therefore that's a membranous VSD over here. You can also see the turbulent shunt which is happening, the grayscale RBCs which are moving across the VSD out there. On the other hand, let's look at this clip. That is definitely an aorta which has lost its septal continuity, and what more, there is an overriding of the aorta that you see on the interventricular septal defect. And also the pulmonary vein is narrow. You can see the pulmonary vein bifurcating. There's a ductus venosus agenesis here, and the pulmonary artery and then the aorta, which should have been left of the trachea, is now to the right of the trachea. So this is a tetralogy of Fellow. This is absent. This is a tetralogy of Fellow with a right-sided aortic arch, with a ductus agenesis which is happening, and therefore we must be careful about 22q deletion in addition to karyotypic abnormalities. And malalignment VSD is the term we use for this. It's not only present in tetralogy of Fellow, also in absent pulmonary valve, PAVSD, common arterial trunk, double outlet right ventricle, so on and so forth. So that's an example of an LVOT abnormality. The sweep is important, as I said, because it tells you about the crisscross which is happening. That is the LVOT that you see here. In the same fetus, this is the RVOT. I've drawn one line across the aorta, one line across the pulmonary artery, and I transplant them here. I find them crossing each other. So the great arteries are parallel or are perpendicular to each other at their origin, and that can be made out by imagining these lines one, and also looking at the sweep. You'll see the aorta coming up this way, and you see the pulmonary artery coming up this way, telling you that this sweep is important. Now this sweep has to be recognized as a part of your study, and once you begin to look and seek for the sweep, you will find cases where you will have no sweep, as you can see in this clip. You will see that the pulmonary artery is coming from the left ventricle, the aorta is coming from the right ventricle, and they are parallel to each other. There is no crisscross at all. Again, here is another case. That is the parallelism that you see as I sweep. You see the arteries are parallel to each other. I'm going to bookmark here. That is the bookmark, and you will see that the arteries are parallel. So once you begin to recognize parallelism of arteries, you will go on to the realm of parallel great arteries, which you see in three conditions: complete TGA, congenitally corrected TGA, and also in double outlet right ventricle. So that is the aspect about the LVOT. Those are the aspects that we have to see about the LVOT. Now, if you look at the connection count, you have already finished 3, and in the LVOT, you have added one more connection, and therefore your score has gone to 4. So out of the 6, you have finished 4, and you move on to the RVOT, and in the RVOT, what is your checklist? Your checklist is that there is a great artery which is coming from the right ventricle. Now remember, the substernal ventricle, that's the sternum. Substernal ventricle is the right ventricle, yes? And from there, you have a great artery which is coming down here. So presence of the great artery, yes. But where is this great artery pointing? It's pointing directly to the spine. Remember, the pulmonary artery has a direct posterior course, points posteriorly. There is an axial bifurcation. If you do an axial view, you will find it bifurcating, and in the sagittal view, it continues as the ductus arteriosus, and just like the aortic valve blinks, you can see the pulmonary valve which blinks. It's thin cusps, and they open and close, they blink during the cardiac cycle. Now, as an example of pathology, let's look at this RVOT. That's the sternum, right ventricle. There's a cardiomegaly that you can see. And this is the right ventricle which is moving out into the pulmonary artery through the muscular infundibulum. So what strikes you is that the valve is not blinking. It's thick, it's dysplastic, and it's seen continuously throughout the cardiac cycle. And when I turn the color Doppler on, I find aliasing. Your color Doppler settings should be such that in your normal heart, there should be no aliasing. And therefore, when there's a stenotic pathology, you will find that your aliasing which occurs actually draws your attention, tells you that there's a hemodynamic disturbance over here in terms of a stenosis. Also, you can recognize that there's a pulmonary regurgitation which is happening there, and that's the 4-chamber view, cardiomegaly, which you see over there, and that's the systolic jetting which you have. So all telling you that you're dealing with a critical pulmonary stenosis, Here is another example that you can see. That's the 4-chamber view of the heart, and the 4-chamber view itself is holding a lot of clues there. Compare the size, first of all. Right should equal the left. Here the right is smaller. Look at the movement of the right mitral valve, opening and closing brilliantly, but look at the tricuspid valve. No, it's not moving at all. So certainly your 4-chamber view itself has given you a headlong clue. Look for the RVOT. When you do your RVOT, you find that the pulmonary artery is narrow. That's the axial bifurcation that you can see. That's the ductus arteriosus going there. This is the aorta. Normally the pulmonary artery should be much bigger than the aorta. Here it is smaller than the aorta. When I turn the color Doppler on, the the diagnosis is written all over the picture. This is the aortic valve showing you transverse aortic arch, which is showing you normal color blue, antegrade flow, but the pulmonary artery, the left-sided great artery, is showing you reverse flow, telling you that this is a pulmonary atresia with an intact ventricular septum. And when you look at the color Doppler on the four-chamber view, you find that the transmitral flow is very, very good, but the tricuspid flow is very little, and whatever little goes is coming back in terms of a tricuspid regurgitation. So that's a right ventricular outflow tract abnormality as an example that I thought I would show you. So what are the connections which are assessed in RVOT? There is the right-sided ventricular arterial that you have assessed. So you finished three in the four-chamber view. You added one more by doing an LVOT, that's the left ventricular arterial. You added one more, which is the right ventricular arterial in the RVOT. So the last one left is actually the SVC and IVC getting into the right atrium. So 5 junctions are over, and if you have to see that, you have to do the hammock view, and the hammock view looks like this. It's also called the bicaval view. You have the SVC, you have the IVC, that's the right atrium which is happening, but we normally don't see this as a part of the mid-trimester anomaly scan, because, you know, if you have all these connections right, you can take the luxury of saying, I'm not going to do this view. Also, you must realize, if you've gone through your checklist, your IVC has already been covered in the upper abdomen. Your SVC has already been covered in the 3-vessel trachea view. Actually, you've already done these vessels in terms of their positional location. So you know that they are normal. You only don't take the luxury of showing them coming and joining the right atrium, which is no big deal. You can take that luxury, right? So lastly, before I let you off and we go on to the questions if there's time, is the 3-vessel view or the 3-vessel trachea view. And we all know about this. I'm not going to take you through to the normal, except saying that you need to recognize the order left to right and the size, and also a straight line arrangement to recognize the thymus out over there, which separates the great vessels from the sternum, and you have the lungs on either side. Remember, the V, which you can imagine through the aorta, through the ductus arch and the aortic arch, moves to the left of the trachea, moves to the left of the spine, and if you begin to have this in your checklist, you will never miss a right-sided aortic arch, right? Now here is some examples that I can show you. That is, okay, this is 2 vessels. Instead of 3 vessels, you see only 2 vessels out there, only 2 vessels coming up there. That's a common arterial trunk. And here is CTGA, again 2 vessels only, 2 vessels, SVC and the aorta, nothing beyond that. Again telling you that this is an abnormal 2-vessel view, and this is 4 vessels that you see here in this, telling you that there's an LSVC. The differential diagnosis here is a supracardiac TAPVC. You can see that's the right side, SVC, aorta, pulmonary artery. There's another one which you don't want to see, and that's the 4th vessel, and that is not an LSVC, because when I come down to the 4-chamber view, I've already realized that the area behind the heart is huge and the pulmonary veins are abnormal. You see the twig over there, which tells me that the twig here and a vertical vein there tells me that we're dealing with supracardiac TAPVC, and if you trace the vertical vein, it'll go and join the left brachiocephalic vein. So that's 4 vessels. This is 4 vessels LSVC, 4 vessels in terms of a supracardiac TAPVC. Okay, so spatial relation. Okay, we'll just do one spatial relation in terms of this particular case, or even this. Okay, let's look at this. That's right, that's left. Okay, from right side, that's the SVC. That's the aorta, that's the pulmonary artery. You need to recognize that the pulmonary artery and aorta are always close together. They are very, very intimately related to each other. And here, in a minute, you know that there's somebody who's coming in between. That's the aorta, that's the pulmonary artery. You have the trachea and the esophagus, which have come here, pushing the pulmonary artery to the right side. So this is the aorta to the right side. This is the ductus arch to the normal ductus arch to the left side, and therefore this is called the U type of right aortic arch. Remember, SVC, aorta, pulmonary artery, both the aorta and pulmonary artery should move to the left. We spoke about the V going to the left. Here the aorta is come to the right side, ductus arch is to the left side. This is U type. Whereas here both the ductus arch and the aortic arch have moved to the right of the trachea. This is called the V type, and here is a double aortic arch. You can find the aorta, which is actually bifurcating and enclosing. This is a loose vascular ring. This is a tight vascular ring. So those are the three vessel trachea view abnormalities that I've tried to kind of bring forth. So equipment setup is very important, fetal position extremely important, and this can be oftentimes trying. You have to wait until you get what you want. And remember, parents are willing to come for days on end to get their baby's heart checked, right? Operator skill is extremely important. Producing those planes is step one. Knowing those planes, what to be produced, is step one. Producing those planes, step two. The most important thing is running your checklist into each of these planes. If you begin to do that, cardiology, fetal cardiology becomes mathematics, and your pickup goes on, becomes manifold. Remember, you don't end there. You look at the fetus as a whole, look for associated abnormalities, extremely important, and then look at the underlying problem. Are you dealing with a karyotypic abnormality? Are you dealing with a 22q deletion? You can ask for a karyotype. You can do an invasive testing. You can do a chromosomal microarray, which bundles the karyotype together with microdeletions together. You can do a CES, a clinical exome sequencing, if you're looking for syndromes. And it's best that you go through a genetic counseling session and decide on what testing for what. And most importantly, the cardiac outcome should be explained to the couple by a pediatric cardiologist so that they know, with knowledge, they make their decision for this particular pregnancy. So the first abnormality picked up leads to a detailed echo and to other findings. Remember, I've put detailed echo in inverted commas because a detailed echo is the norm. You're not doing the fetus a favor. It's up to us. It's expected of us to do the so-called detailed echo and to other findings, and then the final diagnosis. If the final diagnosis cannot be arrived at, you only have a bunch of findings and you're not sure what's happening, you need to seek another opinion. You need to seek another opinion. An example is an axis rotation. You recognize an overriding artery, then you go to the pulmonary artery, you find the pulmonary artery is narrow, you look for the arch, it's left-sided, the thymus is present, your diagnosis now is tetralogy of Fallot, isolated, no other abnormalities, you're going to ask for a karyotype and a conotruncal and a 22q deletion, a fish for 22q deletion. And what is boxed is extremely important: documentation. You have to document clips in every heart that you see, normal or abnormal. You've got to document stills, normal or abnormal. Remember, it's extremely important to do this. So with this, I take leave of you as far as the presentation goes. Do we have time for the questions? Can I take the questions? Okay.